Hello, everyone, and welcome to our webinar today on how to submit a proposal to the Physician-Focused Payment Model Technical Advisory Committee. This is Harold Miller. I'm a member of what we call the PTAC, the Physician-Focused Payment Model Technical Advisory Committee, and I am joined today by my colleague on the PTAC, Dr. Kavita Patel. I'll be handling the first part of the webinar, and Kavita will be handling the second part, and then we will take questions at the end. So just some overall information about the webinar. We will make the slides that we're using in the webinar available to everyone. They'll be sent to the participants, and they will also be posted on the PTAC website, and we'll give you the links for that at the very end of the presentation. We will have time after the presentation for questions. The operator will moderate the questions, and if you have a question to ask at the end, simply signal that to the operator, and we will queue you up to ask a question. You can also, during the course of the webinar, enter your question if you have one in the chat box, which you should see, I think, at the lower left corner of your screen. We're also going to be recording this webinar, and that will also be distributed to the participants and posted on the PTAC website afterwards. What we're going to cover in the webinar today is we'll give you just a very quick review of what the PTAC's role in membership is, and then we will be talking about the process and the key dates for reviewing proposals and submitting proposals, reviewing them, and evaluating them, and the overall timeline that we're currently anticipating for the PTAC to do its evaluation and make its recommendations to the Secretary of Health and Human Services. We'll be going over in detail the kinds of information that we are looking for, and we'll also remind everyone that we are seeking public participation in various aspects of what we are doing, including some comments we are seeking right now, and we will remind you of that at the end, and then also, as I said, take questions and answers about any of this or anything that the PTAC is doing at the end. So first of all, just to clarify for everyone, the Physician-Focused Payment Model Technical Advisory Committee, the PTAC, was established by MACRA, the Medicare Access and CHIP Reauthorization Act of 2015 that was passed by Congress then. And its purpose specifically is to make comments and recommendations to the Secretary of HHS on proposals submitted by stakeholders, individuals and organizations, for physician-focused payment models. We make recommendations. We do not implement payment models ourselves. What MACRA requires is that the Secretary of HHS first establish criteria for physician-focused payment models and then respond to the recommendations of the PTAC. The members, there are 11 members of the PTAC. The PTAC members were appointed by the Government Accountability Office. They were not appointed by HHS or by CMS. So the PTAC members are independent of CMS and HHS in that respect. But we are staffed by the Department of Health and Human Services, the Assistant Secretary for Planning and Evaluation, and we are working as closely as we can with CMS and with HHS staff to be able to make this process a success. The 11 members of the PTAC, the majority are physicians. 7 of the 11 members are physicians. The others are not and come from all different parts of the country. And I would say that I personally have been impressed by my colleagues on the PTAC. I think everyone is very committed to try to use this process to create some really important transformational change and to be able to get new kinds of payment models in place as quickly, efficiently, and effectively as possible, and we are working hard to be able to achieve that. What I'm going to do today is to review the overall process that we are following, and then Kavita is going to talk about the specific information that we're looking for in the proposals. We were actually appointed over a year ago, and have spent the first part of 2016 working to try to identify what processes we should use, et cetera. But I'll just focus on the most recent series of activities, going back to our last public meeting, which was in the middle of September. And at that point, we had a number of people attend the public meeting to provide comments on our draft process and the proposal information requirements, and we continued to accept comments after that meeting. We had been waiting at that point really to have the final criteria established by the Department of Health and Human Services for physician-focused payment models. The initial draft criteria were issued in the spring with the proposed macro rules, and we developed our drafts based on that proposed rule, but we needed to wait until the final rule was issued to be able to finalize all of our materials. And the final rules were issued in mid-October, and fortunately in many ways there were relatively few changes in terms of the PFPM criteria from the spring. So what we have done since then is to revise and finalize the materials that we had, including the request for proposals, which has just been issued, and we are in the process right now of also taking comments on the criteria that we will use for making recommendations. We announced earlier at the beginning of October that we would begin accepting proposals on December the 1st. And we are anticipating that we will receive some proposals on December 1st. Our goal is to be able to make recommendations on those initial proposal submissions by the spring. Some people have had the impression that this is going to be a year or two process for us to make recommendations. We are working very hard to be able to make sure that we can act as quickly as possible while being responsible about our reviews, so that we can hopefully be able to spur more payment models to be in place as soon as possible, including, we hope, as early as 2018. But we simply make recommendations to the Secretary. The Secretary is required by law to respond to those recommendations, but the actual decisions about what to implement and the processes for implementation are really in the hands of the Department of Health and Human Services and the Centers for Medicare and Medicaid Services. And we have been in constant communication and trying to work closely to make sure that those processes are coordinated so that it will facilitate rapid implementation of proposals that are desirable to put in place. So let me do a deeper dive into the steps in the process. One of the things that we have asked for is that at least 30 days in advance of actually submitting a proposal, that anyone who is contemplating submitting a proposal send in a letter of intent. A fairly simple two-page document simply to give us a sense of what is coming, and part of the reason for that is to help us make sure that we are prepared and able to act as quickly as possible when the proposals do come in, by giving us some lead time to be able to organize ourselves about what may be coming. There's no deadline for submitting a letter of intent. There is no requirement or advantage to submitting one sooner than anybody else. It's merely an early warning for us about what may be coming as a proposal. We have estimated at this point that it will take us about 16 weeks to be able to complete all of the steps in the process. And I will describe what all those steps are in the process and why it will take us that long. We don't know for sure exactly how long it will take us, and we will know that better after we have our first set of proposals, because we haven't really been through the process yet. And we will, at that stage, either not recommend the proposal, or we will recommend it. And we are proposing right now to have 3 different kinds of recommendations. One is that a proposed payment model be tested on a limited scale. In many cases that may be because there are a variety of details which really need to be worked out and can't be worked out without actual live testing of the model. It may be that the model actually is prepared for somewhat broader implementation than that, and we might recommend that. And we might also recommend that something seems to be a particularly high priority in terms of its potential impact, and so we may make that recommendation. And as I said, that simply is the recommendation to HHS. HHS could, in fact, also decide, even if we recommended something, not to approve it and then it will need to take whatever time is necessary to be able to implement it, and some models may take more time to implement than others. So you might ask, what in the world takes 16 weeks? First, what we've allocated, and some of these processes, if we can shorten them, we will, but we want to make sure, again, that we've allocated enough time to do them well, is we set aside 2 weeks to make sure that the proposal is complete. We hope to actually do that much quicker than that. And then also, we want to make sure that the members of the PTAC who review a proposal do not have any conflicts of interest with that proposal. So we want to be able to identify that and make sure that those who are specifically involved with the review don't have conflicts of interest. Our hope is we may be able to speed up that process by looking at the letters of intent in advance. Then there will be what we're referring to as a preliminary review team, which will be a subset of the PTAC members. The only people who will be on it officially will be the PTAC members. There will be at least one physician on each review team. The review teams will probably be 2 to 3 people. None of them will have a conflict of interest, and one of the individuals will serve as a lead reviewer. And that will be the subset of PTAC members that will really do the initial deep dive into the proposal and try to identify what questions need to be asked. The preliminary review team will be supported by the staff from ASPE at HHS, the Assistant Secretary for Planning and Evaluation, and we will bring in subject matter experts if needed. Here again, we will make sure we're not bringing in people who have any kind of a conflict of interest, and everyone will know when the proposal comes up for decision who was involved with us in terms of providing expertise. So they will all be publicly identified. The review team will look at the proposal to try to identify what questions we have and what concerns we may have about the proposal. It is possible in some cases that we will have what we view as a sufficiently large number of questions or concerns that really significant revisions are needed beyond what was included in the proposal, and in which case we would just return that to the applicant and ask for a revised application. But we don't anticipate in most cases that that will be necessary, but again, we don't know until we actually see the proposals. But assuming that the proposal doesn't get returned for complete revision, we are planning to post all proposals that we receive for public comment, and we anticipate allowing about 3 weeks for that public comment. That will be an opportunity for us to get any input, advice, comments, pro or con, from people who may be interested in what the proposal is doing. And we will also then be asking the individual or organization that submitted the proposal to respond to our questions and concerns. Some of that may be handled in writing. Some of that may require a telephone or an in-person meeting. It will depend a bit on the specifics. How long that will take really is not completely clear. I mean, it will depend a bit on the submitter and how long it may take them to be able to respond. The sooner they respond, the sooner we will be able to then take those responses and act on them. But I don't know at this point that we will put any deadlines on the submitter as to exactly when they have to respond, because we want to make sure that they have time to respond properly. But once we have the public comments and once we have the responses from the submitter, then the preliminary review team will prepare a report to the full PTAC group as to how well the proposal and how specifically it meets the criteria established by the Secretary of HHS. Under the law, we are reviewing the proposals against the criteria that were established by HHS. So our report and what you'll see in terms of the information that we're requiring is really designed to align with our evaluation against those criteria. That report, and we anticipate the goal is to have that report finished within a couple of weeks after we have the public comment and all of the information from the entity that submitted the proposal. When that report goes to the PTAC, we will then have a discussion and a decision on the PTAC recommendation at a public meeting of the PTAC. So part of the constraint in this will be just the need to schedule a public meeting and to have a proposal considered at a public meeting. We will try to make sure that, obviously, that when the meeting that we consider a proposal at, that whoever submitted the proposal will be able to attend. So if someone can attend a meeting that we have scheduled, that may be delayed on that basis. And it will also depend on the volume of applications. But we are committed to try to have a meeting and act on proposals as quickly as possible. And very likely the first meeting where we do that will be sometime at the beginning of April, which will be consistent with if we get proposals at the beginning of December. That then will be, once the decision is made, we will, within a couple of weeks, turn that into a specific report to the Secretary of HHS, and we will post those reports publicly. Whether it is a report recommending something or a report not recommending something, the report and the reasons for the recommendation will be posted publicly, so that not only the submitter will know what happened, but others can gain whatever benefit they can from the kinds of things that achieved success and the things that didn't. Now, an important thing to emphasize is that there are no deadlines on when proposals can be submitted. This is a completely rolling process. You can submit a proposal whenever it's ready, and in many ways we would prefer that if you need a little bit more time to get a good proposal together, that you take that extra time, because that will make it simpler for everyone whenever we are reviewing the proposal. Submitting a proposal, a few days earlier does not necessarily mean that it's going to be acted on any more quickly. After we complete the review process and at a scheduled meeting. But if you are desirous of having a proposal reviewed and acted upon within a particular time frame, then you essentially have to work back from the 16-week estimate right now as to when the proposal needs to be in order for us to be able to act on it. The soonest we could act on it would then be within that time frame. So hopefully that at least helps everyone plan for that. And with that, I'm going to turn it over to Kavita Patel to talk about the kinds of information that we are looking for as part of the proposals.
Great. Thank you, Harold. And I think just in case, I just want to reiterate a couple of things. The slides will be made available, so fret not. You don't have to try to copy all of this. And then, and then as we're going into the supporting information requirements, or supporting information kind of that we're asking for with the proposals, we want to keep one thing in mind, that there are official criteria that were established in the final regulations, and so the information that we're requesting, and you'll see kind of the cadence of this in the future slides, really supports those kind of secretarial criteria. Recall also that MACRA requires our PTAC to review the proposed models and submit the comments and recommendations to the Secretary about whether each model meets those Secretary criteria. So what we're reviewing and asking people to do is give us supporting information that helps to kind of reinforce those criteria. And if you haven't had a chance to look at the individual Secretary's criteria, we'll go through kind of the broad brushstrokes of that in the next slide. But I also wanted to kind of emphasize, because I would say that one thing Harold and I and others on PTAC have all shared in common is trying to meet a page requirement limit or trying to meet the needs of an application for a grant, et cetera, and feeling like what's being asked of us is way too overwhelming. What we're trying to do with this process is not to ask that you're checking every single box, but that you understand the 10 Secretaries criteria and that the supporting information underneath that criteria helps to reinforce that actual criterion. So it's not meant to overwhelm, and our goal as a PTAC and Harold and I wanted to express this many, many times to those of you that have reached out through public comments during the meetings, is that, and all of the PTAC, by the way, our chair and co-chair included, that we're not trying to find reasons to throw proposals out. We're actually trying to provide you as much comprehensive information that can be supportive of that macro required criteria. So with that, let's go ahead and get into the 10 domain areas for how we will look at proposals. And the first 3 you'll note are actually what we would consider high priority areas, and those we'll just review kind of what that means. But in thinking about putting together your proposal, these first 3 areas are designated high priority, and that would be an area that spending time, all 10 areas require time and attention, but certainly the first 3 areas, because of their high priority designation, would merit kind of thinking in careful detail how you're responding to the supporting information requests. So, and I'll read through the 10 just so that we kind of do it, and then we'll break it down. The scope of the proposed physician-focused payment model. The second is quality and cost. The third is payment methodology. Fourth is value over volume. The fifth is flexibility. The sixth is ability to be evaluated. Seventh is integration and care coordination. Eighth is patient choice. Ninth, patient safety. And 10th, patient health information technology. In that supporting information for that first high priority item, which is the scope of the proposed physician-focused payment model, and instead of, I'll just highlight, I'm going to read quickly through these bullets, but what I'd rather do is also kind of just give a little bit of a pearl about, again, the overarching intention is to find out in kind of this part of the proposal how you are addressing an issue in payment policy, and also kind of what you've already done to think about where APM, alternative payment model entities, might to date have had a limited opportunity to participate in the current alternative payment models. It's also important in this section to just provide, I would say, an overview of the overall potential impact of the proposed model on physicians or other eligible beneficiaries as well as professionals. And then the scope and span of the payment model. Think of this section as trying to just put into kind of an overarching section on how the scope of the actual payment model and what the feasibility would be in implementing the model, along with the clinical and financial risks for participants in the model. The second high priority area is quality and cost. And we did not spell out, because of the room on the slides, what we can do if people are interested is those of you that need to have your kind of refresh on the macro final rule with the Secretary's 10 criteria, what we did as a PTAC is try to bring this and distill it into these slides for you so that as you're reviewing how to put a proposal together, it just makes more sense for how you write it, but might be smart to kind of sit with the Secretary's criteria, what we have provided you in the supporting information, and then just think about how you put the proposal together through our PTAC website process. So I won't get into that since that's a little bit beyond the scope of this webinar, but I'll just say that for the section on quality and cost, which is also a high priority area, this section really we're hoping to get information that illustrates how the proposal either improves health care with no additional cost, maintains healthcare quality while decreasing cost, or both improves healthcare quality while also decreasing cost. So those kind of reverberate back to things that the administration have talked about in other alternative payment models. And so really at heart of this section is understanding what is the value proposition proposed by the physician-focused payment model. And according to that, the proposal this section should address any current barriers to achieving quality goals, and that could include identification of novel clinical quality measures, or in particular how measures related to outcomes and beneficiary or patient experience could be noted. We have acknowledged through your public comment that many of you want to understand how you can advance some of the fields of quality, and we want in this section for you to be able to support that. The next section is on payment methodology, again another designated high priority area. And this supporting information that we've asked for in this really doesn't deal with the nitty-gritty of the payment methodology, as well as whether that methodology applies to other payers and how the payment model would actually change payment for the alternative payment model entities, and how that might be different from current payment models, and why this could not be tested or why you could not do what you're proposing under the current payment environment. I think it sounds like that might be intuitive. You wouldn't propose a model if you could do it in current fee-for-service environments, but we just want to get a sense. And again, I'm going to keep saying the same thing. The goal is not for you to go through every single bullet or line and check, but we want to just reverberate that this section on payment methodology should give us a much better sense after you've written it on how you describe the actual transaction of the dollars and how that might be different in the current payment model, in the current system versus what you're proposing. And then finally, what we'd like to do is make sure that in this section the supporting information talks about physicians or other eligible professionals in achieving the objectives, as well as the financial risk that the entity or physicians might bear in this model. And that might include, by the way, the regulatory barriers that either need to be dealt with at the local, state, or federal levels that could affect the implementation of the proposed model. We know that many of the current CMS alternative payment models have a great deal of waiver authorities, obviously at the federal level since that's what CMS's jurisdiction is, but there are certainly local and state kind of regulatory issues that might be appropriate to bring up in the model depending on what your kind of proposed methodology would be. And this would be the section to do that. So just wanted to reiterate that. Then we move into other areas that, while they're not designated as high priority, they're certainly important to meet the needs of kind of giving us the most comprehensive proposal. The next section is, quote, value over volume. And we understand at the PTAC that that's a very generic phrase. So what we'd like to do in this section is understand how practitioners' behavior to achieve higher value through the model, through the proposed model, could actually be promoted. And so there's a lot of incentives that can help people to move care towards value, and we've certainly been talking about financial ones, but there could be non-financial ones, and there could be unique arrangements around staffing, around patient incentives, and other innovations that we think could provide that same value and would help to create a better alignment kind of over volume. So this is, again, another aspect of kind of just giving us whatever you can to illustrate how you're generating more towards a drive towards value. The next section is flexibility, and this is really to give us a better sense of how the proposed model provides any flexibility required for practitioners to deliver high-quality health care. So how would the proposed payment model accommodate potentially different types of practice settings, different types of patient populations? Is the model flexible enough to include novel therapies and technologies, for example? And are there any infrastructure changes that might be necessary for a physician or other eligible professionals to succeed in the proposed model? And we have, by the way, these slides we have obviously in our longer documents that are on our PTAC website, even much more comprehensive kind of descriptions and lines. What we're really trying to strike a balance in these slides is to give you kind of the top level kind of goals of each of the sections. I would say that in this section the PTAC committee had a very strong discussion on trying to understand what would a practice or what would an APM entity or any sort of institution need to put into place, and how much of that is rigid in such a fashion that would require upfront investments, et cetera. So this section really is trying to give us, the supporting information is trying to give the PTAC a sense of, if we were able to start this proposed model today, what would some of the physicians and practitioners need to do in order to succeed in that model? And does that take additional infrastructure requirements? And then the next section is the ability to be evaluated. Again, these are all kind of correlated back to Secretary's criteria, and we really want to understand if there are truly evaluable goals for quality of care, cost, or any other of the express stated goals of the physician-focused payment model. So we know that evaluations are a very common phenomenon in alternative payment models. However, we want to understand how you as a proposer of the model would actually propose the evaluation, if there are any evaluations that have been done to date or are currently underway. That would also be helpful to include in here. And if there are also difficulties in conducting a full evaluation, this would be an important place to say, here are some of the challenges, here are some of the barriers, here are why, practically speaking, it would be difficult to conduct a comprehensive evaluation, so here's what we would propose for addressing some of those challenges. The next section is on integration and care coordination. One of the other explicit criteria from the Secretary is kind of encouraging greater integration and care coordination amongst practitioners. So we would want in this supporting information to understand the full range of personnel and resources that would need to be deployed to accomplish the proposed model's objectives. And again, in our longer written documents, not the slides, but in our longer RFP, we have some of these examples that can help to give you a sense of what this means. And for example, will this proposed model enable better care coordination across non-health practitioners as well as potentially the frontline workers within your institution, such as medical assistants or community health workers, et cetera? And we also would like to know in this section how such a model might alter traditional relationships in the delivery system. I mentioned relationships with non-healthcare entities, et cetera. How would that improve care coordination for patients? This would be the section where if your model addresses any of those issues, this would be a place to include that information. I'll state it again. These are not intended to be, must-pass box-checking exercises. If you don't have a narrative for every single one of these lines, do not consider your proposal deficient. And certainly Harold can weigh in on this and anybody else in the PTAC. But it's more that we need to have as much as possible because the only thing we have is what's in your written proposal. And if you do not have elements in your proposal that address all of this, do not worry. We do need, however, to have those high priority elements and have at least some written sense of why you may not be addressing certain aspects in your proposal. So do not feel that you need to alter your payment model just to include something for every single line item. Next section is patient choice, and this is an area, this section and the supporting information is really to understand how patient choice might be integrated into your proposed payment model. And this could be everything from just acknowledging that you're dealing with, that your payment model is dealing with a special population that has unique needs and unique preferences, but it could also just be addressing, for example, how the demographics of your patient population or social determinants might be addressed through a different model of payment. So we're leaving this, again, to be intentionally broad, but the goal in this section would be to understand how you might be thinking about patients and beneficiaries in involvement in the proposed model. And let me just move. Keep forgetting I'm the one that's moving the slides. All right, the next section is on patient safety, and this kind of follows a little bit on the theme of patient choice, but this is distinctly different in that it deals with kind of how your proposed model would protect any unintended consequences, potential disruptions in healthcare delivery brought about by changes in the payment methodology or incentives. And this should be a concept of safety that is interpreted to be inclusive and not just facility-based. So I'm one of the physicians that Harold mentioned that's on the PTAC, and sometimes when we talk about patient safety, we talk about hospital-based safety requirements or clinical, ambulatory-based safety. What we're really trying to address is how any unintended consequences or potential safety gaps could occur and might be mitigated or even improved because of the proposed model. So it leaves a lot of room for interpretation, but here again the goal is to understand how could safety, any safety jeopardy be minimized or safety be improved overall. And then the final section is on health information technology, and we wanted explicitly to make sure that this isn't focused on technology for technology's sake, but I would drive your eyes to kind of understanding how you can help the PTAC interpret the role of information technology for the goal of better data sharing, for interoperability, and for overall just better delivery of care. So we're not necessarily, some of you provided in both writing as well as oral feedback, this isn't really intended to kind of deal with, are you a meaningful user, et cetera. You may want to mention that if you feel like that's important, but this is really more about how health information technology in the proposed payment model will accomplish the model's objectives and actually enhance the consumer experience and efficiency of the care delivery process. So this would not necessarily constitute, I know in some of the other alternative payment model or CMS kind of models, you have to talk about very specific technical requirements. This is really about health information technology having a role in some form or fashion in the proposed payment model to achieve the model's objectives. So that's really the driving goal. That really highlights the 10 kind of domains, and I mentioned that we really, for the purpose of putting things in slides, just glossed over things by putting them on one slide, but we have obviously a lot more language that's in the full RFP on the PTAC website. So I would encourage any of you that are thinking about a proposal, like I said, to just sit down with that document in front of you, and that can help to really understand the comprehensiveness, with keeping in mind that our goal is not to find things that you're missing to disqualify you, but that if you can address each of these areas, because they do map back to the Secretary's criteria, that's really the spirit of what we're asking for with the supporting information. We do have a section outside of our 20-page requirement that would be supplemental information. So we just wanted to, without overdoing, giving us 200 pages of supplemental information is probably not the spirit of what this is, but if you have, for example, a proposed governance structure for an alternative payment model entity in the new proposed payment model, this would be a good place to potentially put that governance map forward. And then if you know that there are infrastructure investments that might be needed from CMS, in addition to changes in the payment model. And this really squares with our PTAC's experience in alternative payment models and how we have watched over the years the needs that all types and sizes of practitioners have had, including different mechanisms for potentially claims, data, quality. This would be a good place to include that supplemental information. So we wanted to offer, outside of the page requirements, a place for you to put this that would make sense for you to be able to discuss these issues. Let me just go ahead and then now quickly go through, I see we're doing okay on time. These are just the kind of nuts and bolts for submitting the proposal. Harold already mentioned that there is no kind of drop deadline, that we're doing this on a rolling basis. We already, as he mentioned, began accepting the letters of intent. There's the link just in case you have not found where all this is, and we will begin accepting full proposals on December 1st, and that kicks off that calendar that Harold showed you in that slide several slides ago. And then we can also, just in terms of getting your feedback, I think none of us think that what we've presented to you is going to be the final form of everything. We are ourselves a continuously quality improvement organization, kind of a set of minded people. So it would be wonderful to continue to receive your thoughts in writing if possible, because I know some of you have reached out to individual PTAC members over email or over the phone. We all have some knowledge of each other in some fashion, but what we would love is to have some of these comments officially on the website, as well as any other kind of additional thoughts that you might have. We feel like this is a unique opportunity to hear from the public, so Harold and I cannot emphasize that enough, and that the more feedback the better, especially early on. And then we do have obviously more opportunities for in-person participation. And then here's the email that I mentioned with questions, comments, etc. And hopefully this will, any of you who have either formal or informal questions or just even a short comment can use that process in some way. So I will stop and ask for the operator to turn over the process to questions. But actually before I do that, I turn it over because Harold has been dutifully monitoring the chat box. So Harold, are there some chat questions we want to do first?
There are. Let me let the operator first ask for questions, and then while we're waiting for people to sign on the phone, I'll answer a couple of questions that came in on the chat box. So operator.
Thank you very much. Ladies and gentlemen, if you would like to register a question over the phone lines, please press 1-4 on your telephone keypad. You will hear a 3-tone prompt to acknowledge your request. If your question has already been answered and you'd like to withdraw your registration, you may press 1-3. And if you are using a speakerphone, we ask that you please lift your handset before entering your request. Once again, ladies and gentlemen, for any questions, please press 1-4 on your telephone keypads now. One moment, please, for the first question.
So while we're waiting, a couple questions that came in the chat box. One was whether HHS expressed willingness to actually consider, I talked about the two kinds of recommendations, recommending for implementation on a limited or pilot basis or full implementation. In general, most projects would need to be tested. That would be the primary authority as opposed to broad full implementation. What we're trying to distinguish in some ways is whether something really needs to be done on a small pilot basis. And I think at least in the discussion so far, there's been general agreement that that might be desirable. Everything about testing any of the models will depend a bit on how many things there are to test and what the resources would be necessary to be able to put them in place. What we didn't want to do was to suggest that somehow things were ready to be done in 1,000 different practices around the country if they weren't, or to suggest that they could only be done in a dozen places if in fact they could potentially be done more broadly. So we'll be working with HHS on that. Other question that came in was whether or not, what's the pool of outside experts we're going to use as proposal reviewers. I would say, first of all, our hope is that the public comment process will actually provide us a lot of outside expertise to use. And so if there are people, for example, from the medical specialty that are involved with a particular area of care that would be affected by a proposal, that they will weigh in through the public comment process. It won't be the case that we will be picking some expert who will be the sole source of information about how a particular specialty would be affected by this. We will be, if we need to have someone really give us a deep dive, we have some contractors who will be able to recruit folks to help. And I think in general, the nature of the conflict of interest would simply really be whether or not the person was involved with the proposal per se, or would be in some fashion uniquely likely to benefit or be harmed by it. Beyond that, since these are intended to be models that will affect particular kinds of physicians, people who are physicians like that, input will be welcome, and we will be seeking that. But I would emphasize the goal of getting it through the public comment process. So let me turn it back to the operator to see who may have questions.
Thank you very much. We do have a couple of questions. Our first question comes in the line of Joel Brill with Joel Brill, MD. Please go ahead.
Good afternoon, Harold and Kavita. How are you?
Good. Thanks for calling.
Good.
A couple of very quick questions. Number one, in the initial discussion, you talked about the 30-day window between the LOI and submitting the proposal. Is that 30 days or is that approximately 30 days? And by that, what I mean is, for example, if one were to submit a proposal, probably an LOI on the 25th of November, could you submit your materials on the 24th of December, or do you have to wait until the 25th of December and afterwards in order to submit your proposal?
I would say that, as Kavita said, our goal is not to find reasons to reject things. So I'm not sure anybody will be worried about something being one day off in one direction or the other. But the idea was to make sure that we had enough time, and that was why we defined the 30 days, to be able to make sure that we could actually read the materials and start thinking about what expertise we needed to be able to draw into it. So if you submit a proposal sooner than 30 days after, it may simply mean that we won't be able to consider the proposal immediately upon submission. I don't think we would reject it simply because it came in a day or two earlier than the 30-day definition, if that helps.
Thank you for the clarification. In the discussion of the 20-page versus the supplemental limit, one question that has arisen is, how does one indicate the number of practices or potential sites that might have an interest in participating in one of these models? Would those materials be part of the supplemental, or would that be part of the 20-page proposal itself?
That would be part of the 20 pages, and that would go, it can go in a couple of areas, but that would be helpful to put in that first section on scope to understand kind of what the kind of impact would be on numbers of practices or providers. That would be a good place to include that. But that would definitely go into the actual main proposal.
And along with that, you had mentioned during your presentation some issues relating to infrastructure and the like. So if you've identified infrastructure needs, but they're not necessarily at a CMS level, but those may be at the practice level, again, those would be addressed within the 20 pages, not within the supplemental materials?
Correct. So, and again, the infrastructure, just to help emphasize what the point of that was, it really is to speak to what I think you know and a lot of people on this webinar know, that doing anything differently sometimes, well, most times requires some infrastructure, and that can come in the form of people. It can come in the form of investments in technology. It can also come in the form of just changing workflows. So we want to know what would, walking through this, if this proposed model were to go forward, what would it likely need, what kind of infrastructure changes would likely need to occur to help someone succeed in this model? And that would go in that section called flexibility. That would be the right place to include it. And again, to kind of, I know, because when I have to write things, I'm so sensitive to space constraints. You could write 20 pages on infrastructure changes. I'm confident of that. So what we really want to do is be able to capture a sense of, our proposed model would likely require these infrastructure changes as evidenced by our experience in the following settings, or based on our kind of work in doing this, with practitioners, et cetera. So I'm not trying to write this for you, but we don't want you to completely feel constrained that you take up all this room to also address that.
So let's see what other questions we have on the phone.
Thank you.
And our next question comes in the line of Kate Steniford with the American Academy of Physical Medicine and Rehabilitation. Please go ahead.
Hi, thank you for your presentation. And I have sort of an involved question, but I want to find out, first of all, the types of organizations that can submit models. Do they have to actually be practicing, or can they be like an association, a specialty association? And if it can be, how will the actual practices that could put it into operation know about it? Will CMS, once they make a decision, post that somewhere? Will anybody be able to then use it? So can you borrow off of somebody else's model, that sort of thing?
So first of all, anybody can submit a model, and this is not intended to be simply an entity itself who wants to be paid that way submitting a proposal. It could be anybody. It could be a medical specialty society. It could be somebody who has a really good idea about how payment should change can bring it in. Our role is to evaluate that proposal and to make a recommendation to the Secretary of HHS as to whether we think that merits implementation or testing on a narrow scale or not. Any model that then gets recommended and HHS agrees with will need to go through some additional development to actually be able to put it in place. There might be an RFP process then to invite practices to participate. It might be simply made open on a voluntary basis to anybody who qualifies for it. I think that will depend a lot on the nature of the specific model and the sense of how well developed it is, et cetera. So I think that there'll be many steps before something actually gets into place. I doubt that there would ever be a surprise that a model got into place and that and people had trouble learning that it actually existed. I do think it's important that if someone is not actually an implementer, someone is proposing a model, it will be very helpful to us, obviously, if that entity submits comments of some kind or letters of support or whatever from practices that would actually implement it, because it doesn't really make any sense for us to be recommending a payment model that nobody wants to implement. So if you're not yourself an implementer or you're only one practice or health system or whatever, having support from others will be helpful. Not essential in the sense that that's nothing that it won't be considered at all, but it will certainly be something that would increase, I think, the likelihood that we would feel that it was a desirable, feasible, flexible, meeting all of those various criteria and potentially getting priority. I don't know, Kavita, if you want to add anything to that.
No, that's perfect.
Okay, other questions on the phone?
We have no other questions, sir.
We had one chat. I just wanted to, there's a chat question that asked, Sandy Marks asked if a proposal developer feels they need more assistance to complete one or more aspects of their proposal, what should they do? I'll say that as a PTAC member reviewing the proposal, we can't, I would definitely encourage, while we're not providing technical assistance to complete the proposals in terms of, kind of proposal writing, I would strongly encourage you to reach out to the PTAC staff to determine, because we do have some resources where we can offer some help. And I don't know, Harold, if you want to speak to some of the things that we're trying to do along data elements and things like that. But we, as a PTAC, we would not be able to actually kind of help to actually write any of the proposals that then we would have to review as a body. So
right. We recognize the data is really a challenge for a lot of people, and what we want to get in terms of data is as much as you can assemble from whatever sources that you can assemble, and we will then be able, we will be working to try to find some ways to be able to provide better access to other data sources. We asked at the September meeting for people to give us specific suggestions as to the kinds of data they needed help with, and we will probably be following up with some additional requests along those lines in the near future. Other questions that came up through the chat box were to clarify the relationship between the Innovation Center and the PTAC. The two entities are the PTAC is an independently created and independently appointed group of individuals. We are receiving staff support from ASPE, which is a different set of staff within HHS than CMMI. But the decisions about what the PTAC does are made by the PTAC, and in fact, whether we recommend a proposal or not will be something that the 11 members of the PTAC will do at a public meeting after taking public comments. We have been trying to work closely with CMMI to try to discuss what potential areas of what challenges they particularly face in terms of implementing payment models, et cetera, so that we can consider those issues when we're making recommendations, with the goal being that if we recommend something, it will be something that is much more likely to receive a positive recommendation from CMMI. But there may well be cases in which we recommend something that CMMI has not been interested or wanted to do in the past, and hopefully we may be able to help facilitate thinking differently about that. So the goal is to work collaboratively, but we are independent. I'm sure a lot of people, and one question that came up was, so is this all going to change under the new administration? And I don't think anybody at this point obviously can predict exactly what's going to happen, but the PTAC was established by Congress with an overwhelming bipartisan vote. And I think that the PTAC and the goal of having physician-focused payment models and the goal of encouraging and facilitating the ability of physicians to participate in alternative payment models was a very clear, strong expression by Congress in a bipartisan fashion. So while it's difficult to know exactly what's going to evolve over the next year or two, I personally think it's safe to assume that this notion of alternative payment models and physician-focused payment models and the PTAC process will likely stay in place, and I think that its success will really depend on the quality of the proposals that we get, and so we would really encourage everyone to continue with the process and send us good proposals that we can review and recommend. Operator, any other questions on the phone?
We have no other questions, sir.
Another question that came up was about Medicaid versus Medicare. The definition of a physician-focused payment model is something that affects Medicare beneficiaries and can be implemented in the Medicare program. It doesn't have to be restricted to that, and in fact, in many ways, I think proposals that can be implemented across a broad range of payers and patients would certainly be desirable. But something that is specifically focused solely on Medicaid really does not qualify as a physician-focused payment model under the criteria as they exist today and as were adopted by the Secretary of Health and Human Services. But my guess is that many kinds of issues will affect both Medicare and Medicaid patients. So I think the issue is if you're defining a model that you want to benefit Medicaid patients, try to make it clear how it will also potentially benefit Medicare beneficiaries in order to have it considered by the PTAC. I don't know, Kavita, did you see any other questions? Yes, we will make the slides available. We have been receiving letters of intent, and we are hopeful that that will result in proposals for us to consider in December. Just to emphasize with everybody, a letter of intent does not require anyone to submit a proposal afterwards. It does not obligate you to submit a proposal within 30 days, but I think that the letters of intent we have gotten so far indicate that there is a significant interest and a diversity of interest out there. One other thing I will add, and I'll see if Kavita wants to add anything else before we close. There is a whole section in the RFP which I think it's important for everyone to read, which is called Characteristics of Physician-Focused Payment Models Likely to be Recommended by the PTAC. And we wanted to make sure that people could see the forest for the trees, in a sense, in terms of what we're looking for. We have lots of individual criteria that we have to meet and information that we need for that, as Kavita described. But we wanted to convey the kinds of things that we think we're interested in being able to see. Now, I want to emphasize, as it says in that section, that we will not be exclusively focused on the things that are listed in that section. We actually wrote that section more to be able to make it clear to people that we weren't thinking more narrowly than that. That a lot of people think that somehow the only models that we are interested in are things that look like existing CMS models or are bundles or are episodes. And what that section tries to define is that we are actually looking for a broad range of different kinds of models. We simply want them all to have important characteristics, such as being able to improve quality and reduce spending and be accountable for outcomes. So I would encourage everyone to read that carefully. Kavita, anything you want to add as we close?
No, I think that summarizes. Some people have, the slides will be made available on the PTAC website, so do not worry. And I would like to tell you I would know how quickly, but I know it'll be as quickly as I can do it.
Great. So thank you, everyone, for joining us today. Please do visit the PTAC website and sign up for the listserv, because that's our most efficient way of being able to keep you updated on that. We also do have a Twitter account if you want to follow us on Twitter. And we look forward to seeing you at our next public meeting, and we look forward to reviewing the proposals that you submit. So thank you for joining us today.